Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
My name is Dr. Eric Zingi. I'm a thoracic medical oncologist, assistant professor at MD Anderson Cancer Center. Very honored to be here with all of you in Medscape to produce this event and really talk with colleagues about the HER2 evolving space for our patients with non-small cell lung cancer. So excited to be here. All right, so this is going to be a focus, like I mentioned, on HER2-activating mutations in non-small cell lung cancer. I've introduced myself, but I'm going to go ahead and introduce my esteemed colleagues and dear friends and faculty. First, we have Dr. Thomas Newsom-Davis, who is a consultant oncologist at the Chelsea and Westminster Hospital in London. Dr. Davis, thank you for being here.
Thank you very much.
And then we have Dr. Stuart Yang, who's an assistant attending pathologist at Memorial Sloan Kettering Cancer Center in New York City. Dr. Yang, thank you for joining.
Thanks so much.
Our agenda for today is first to have Dr. Yang talk about understanding alterations and testing in the HER2 space. I will next talk about the evolving treatment landscape for our patients with HER2-positive non-small cell lung cancer. And then Dr. Newsom-Davis will talk about how we educate, empower, and engage our patients and really underscore the value of continuity of care in this setting. So Dr. Yang, I'll let you go ahead and get started.
All right, thanks so much for that introduction. I'm really excited to be here today to talk a little bit more about HER2 biomarkers in non-small cell lung cancer, focusing on the different types of alterations as well as different testing strategies. So I just wanted to start off with sort of this remarkable evolution of biomarkers in non-small cell lung cancer, right? So we started off with KRAS in 1987, added EGFR to the pie in 2004, and now in 2025, we're in the molecular era where we're understanding that lung cancer is really driven by both common and rare genomic biomarkers, many of which can be targeted with specific therapies. And today I'm going to be talking about one of these biomarkers, HER2, as an important oncogenic driver and now an actionable biomarker in lung cancer. So just a little bit about sort of the basic biology. HER2 is a receptor tyrosine kinase protein that is encoded by the ERB2 gene in chromosome 17. So HER2 is the protein and ERB2 is the gene. However, HER2 can also be used as sort of a broad biomarker terminology to include the gene, protein, and pathway. So you're going to see this used potentially interchangeably with ERB2. So structurally, HER2 has extracellular domain on the outside, a transjuxtamembrane domain in the middle, and then the tyrosine kinase domain, which serves as sort of the main engine. And in normal cells, binding of the ligand to HER family receptors will cause dimerization with HER2, and that's going to lead to activation of HER2 and then trigger downstream signaling cascade through RAS and PIK3CA, which are important for survival and proliferation. Now, in HER2-positive lung cancer, you can have specific mutations in ERB2, most commonly in the tyrosine kinase domain, and that's going to cause overactivation of HER2 and therefore tumorigenesis. You can also have increased gene copies or ERB2 gene amplification. That's going to lead to HER2 overexpression, and that's going to cause, again, overactivation of HER2 signaling and therefore tumorigenesis. So based on these mechanisms, we know that there are three types of alterations. 1, ERB2 gene mutation, 2, ERB2 gene amplification, and then 3, HER2 protein overexpression that are important oncogenic drivers in lung cancer. And so we're going to talk a little bit more about each of these biomarkers in this talk. So starting off with the activating ERB2 mutations in lung cancer, there are three main subtypes. The first and the most common and the most important, I think, are the tyrosine kinase domain mutations, specifically the exon 20 insertions, which occur in about 50 to 60%, even some higher in 70% of patients. And then you also have these rare trans or juxtamembrane domain mutations, as well as extracellular domain mutations, which are rare, but they can occur in about 5 to 20%. Now, in generally, ERB2 mutations occur in about 2 to 3% of adenocarcinomas. They have a worse prognosis. And clinically, they're seen in patients with never or light smoking history, Asian heritage, as well as female sex. So it kind of mirrors the EGFR landscape. However, it's important to recognize that these mutations can occur in patients lacking these clinical characteristics. So it's really important that all patients with advanced non-small cell lung cancer and adenocarcinoma be tested for HER2, regardless of clinical or pathologic features. And then I'm going to quickly talk about ERBB2 amplification. So we know that de novo ERBB2 amp is seen in about 2 to 5% of lung cancer, but the higher level amplification is actually seen in a smaller subset, around 1%. And in contrast to the mutations, these are actually associated with male sex and have positive smoking exposure. Now, ERBB2 amplification has also been seen as a bypass mechanism for acquired resistance to targeted therapies like first-line osimertinib, and these can be seen in about 3% of patients who are progressing. So this is an important biomarker for both primary and treatment-resistant non-small cell lung cancer. Now, finally, talking about HER2 expression, this here we're using immunohistochemistry or IHC to measure the intensity of membranous staining from 0 to 3+, 0 being basically no expression, and then 3+ having the highest level of expression. And HER2 overexpression, which is 2 to 3+, is a poor prognostic factor, seen in about 13 to 20% of patients. But 3+, which is the highest score, is seen in about a smaller subset, around 2%. Now, there has been variable sort of concordance between the amplification and overexpression, but there's been a higher concordance and a tighter correlation at the very high levels between high-level ERBB2 amp as well as a 3+ score. There's no correlation with the mutations. Now, why are HER2 biomarkers important in patients with lung cancer, right? So Dr. Singh is going to go into greater detail talking about the clinical and therapeutic data, but I just wanted to give a very sort of high-level preview of why HER2 biomarker testing is so important in patients with lung cancer. So starting off with activating ERBB2 mutations, we have trastuzumab deruxtecan, or T-DXd, that's been approved in the second-line setting. And there are also clinical trials with next-generation TKIs that are ongoing. And so based on the T-DXd approval, the ERBB2 mutation is a clinical-grade biomarker that is included in the NCCN guidelines and then should be tested as a broad panel. And then for ERBB2 amplification, there are actually no specific approved therapies for this space, but it may actually predict overexpression by IHC. So this is a more of an investigation of biomarker that can be tested. And then lastly, for 3+ IHC, we also have T-DXd approved in the US for patients with advanced HER2-positive solid tumors in a tumor-agnostic setting, which of course includes lung cancer. And so this is an FDA-recognized biomarker. And right now, there still is some different sort of testing strategies that we're exploring and how to implement this testing for our clinical patients. So now we talked about that, these biomarkers are, really actionable targets in lung cancer now. And so the next question is, how do we go about in testing our patients for these alterations? So today I'm going to be focusing on different types of assays that we can use to test for ERBB2 and HER2, focusing on the ERBB2 mutations and also the overexpression given their FDA approval. So starting off with ERBB2 mutations, we can use a PCR-based hotspot assay. So here we're detecting known hotspot mutations like single nucleotide variants or in-frame insertion deletions. It's quite rapid, it's cheap, low DNA input requirement. But one big thing is that it's not able to detect all the mutations, right? Because it's a hotspot assay and it can actually miss some important exon 20 insertions. We can also think about using fragment analysis sizing assay. And here we're looking at different insertions or deletions within key gene products. And so this is really ideal for detecting the exon 20 insertions and has similar characteristics as PCR, but the big sort of downside is that it cannot detect SNVs, which can be important for patients with HER2. And then lastly, we have next-generation sequencing, right? This is massively parallel sequence to detect all mutations. Even though it takes longer, it's more expensive, requires a lot of bioinformatic infrastructure, it can detect and genotype all hotspot and rare ERBB2 mutations, as well as other alterations that are important in lung cancer. And one point that I wanted to emphasize here is that not all ERBB2 mutations are activating or actionable. So this figure shows the landscape of all ERBB2 mutations that were detected by NGS in a large molecular database in lung cancer called the GENIE database. And each sort of point represents one mutation. And then now when I filter this mutation for the activating mutations, which are, again, the three main subtypes, we see that we have a smaller number of mutations. In fact, only about half of the ERBB2 mutations are actually activating and actionable. So, what this means is that it's important to obviously detect for these mutations, but it's also equally important to actually figure out which ones are activating and actionable. And so how do we go about in doing that? So first, we can actually just look for the hotspot mutations that we talked about, like the exon 20 insertions, as well as some other rare and recurrent mutations. We can also think about using these somatic variant annotation databases that could be really helpful for annotation. My favorite is OncoKB. It's very user-friendly. It's easy to understand. And then you could also consult a molecular pathologist or other experts. And thankfully, these days, I think all molecular reports have provided some sort of annotation given the recent guidelines from these societies. Now, moving on to HER2-IHC, here we're actually using the HER2 guideline for gastric and GE junction cancers because that's what was used in the pan-cancer approval, so that's what we should be using for our lung cancer patients. And here, since the 3+ is the actionable biomarker, it's really just distinguishing 3+ and not 3+. And right now, the specific guidance on how to implement testing is in progress. So, we talk about the different types of assays, right? And the next question is, how do we integrate these assays to create a clinical strategy or workflow to implement HER2 testing for our patients? So I'm going to talk about the 3 most common clinical scenarios that I encounter in my clinical practice that I think will highlight some of these important issues. So starting off with de novo treatment-naive advanced non-small cell lung cancer, we really want to start off with NGS, right, for HER2 and other biomarkers. So here, when we have mutation, that's great. We can also detect AMP, and in that case, I would actually consider doing IHC given the tight correlation with AMP as well as 3+ IHC. Now, the value of doing upfront IHC in these patients is sort of unclear at this moment because it's so rare and it's not going to influence first-line treatments in this setting. Now, we can also have advanced lung cancer patients that are progressing on therapies, and a lot of these patients have already undergone NGS, so we already should know the ERBB2 mutation status, but because the IHC is so new, we're not going to have the IHC information for most patients, so we would consider doing IHC. And then in the minority patients, we are still not doing complete NGS testing. And so here we would want to do both IHC as well as NGS and perhaps PCR. But if PCR is negative, we want to do NGS because it's a hotspot assay. And then the last scenario is painful, but all of us understand. We have sometimes cases where we have scant tissue that's insufficient for comprehensive NGS, but we still need to assess for all HER2 biomarkers. And for that, I would prioritize doing IHC and PCR, which has lower minimum tissue requirement. And for here, if you have a mutation, that's great. However, if it's negative or insufficient, then I would actually consider doing liquid biopsy using NGS. So I just wanted to quickly talk about using liquid biopsy for HER2 testing. We all know that liquid biopsy testing using ctDNA is really helpful, especially for cases where we have insufficient tissue biopsies or where if tissue biopsy is not feasible. But we also have to understand the important limitations of liquid biopsy, right? Sensitivity is really dependent on disease load, stage, and ctDNA shedding. And when you have a negative result, you really need to go back to tissue to confirm that. And so here in this context of HER2 testing using plasma, if you have a mutation, it's really ideal for mutations. Sometimes if you have high-level amplification, you can detect it as well. But if there are, again, no alterations and if the IHC is unknown, then we really need to go back to the tissue. And so, how do we go about in making sure that we're doing, the best care for our patients in terms of diagnostic testing for HER2? And I think it really starts out right at the beginning with adequate tissue procurement and collection using rapid on-site evaluation, making sure that we're doing appropriate sample preparation and storage, and then making sure that we're doing accurate diagnosis using minimal stains to actually conserve tissue for biomarker testing. And of course, we have to initiate biomarker testing. My opinion is that it's, really ideally we should be doing this in a pathology-initiated reflex workflow where we're using IHC, PCR, as well as NGS. And then, finally, and most importantly, we need to have timely and understandable reports with all the biomarkers and their actionability clearly annotated and defined using the latest guidelines and recommendations. And so, all of this, is easier said than done, right? This process is very complicated, and there are a lot of challenges, I think, but also potentially solutions that I think unique to HER2 as well as other biomarkers that can be applied. So one thing is, we still have limited awareness regarding HER2 biomarkers in the community. It's rare, it's relatively new. So I think it's really important that we continue to raise awareness for HER2 testing through education, advocacy, and outreach. Again, we talked about this issue where we have inadequate diagnostic tissue for complete biomarker testing. And for that, I really think that we can incorporate ROSE or rapid on-site evaluation. Consider using singleplex testing, such as PCR, that have less tissue requirement. And then consider doing liquid biopsy testing for mutations in select patients. And then, we still have lots of gaps, delays, and inefficiencies in biomarker testing because we have to add HER2 along with all the other biomarkers. And so I think one potential solution is really to incorporate pathology-initiated reflex testing protocol that can expand testing rates, reduce testing bias based on clinical characteristics, and minimize turnaround time, and just increase the overall efficiency of the process. And then lastly, I think there's still a lot of confusion regarding HER2 biomarker testing results, right? Is this mutation activating? Is it actionable? Is this 3+? Is this amplification? And I think, it's really important that we continue to standardize nomenclature and variant annotation along with multidisciplinary collaboration and discussion. That's going to really, I think, help improve understanding and interpretation of HER2 biomarker testing results for our patients.
Perfect. Well, thank you, Dr. Yang. That was a fantastic overview of the testing and solutions that we need to come up with for our patients to really deliver the treatments that we have. So I am now going to segue into talking about the evolving treatment landscape for our patients. First, before we get into the evolving treatment landscape, we need to understand the current standard of care guidelines, and so we'll review those together. This is the NCCN guidelines, which many of us refer to, trying to better understand what is our current practice for patients with HER2-positive non-small cell lung cancer. And I'll walk us through it. Dr. Yang very nicely talked us through how to identify the mutation. That is really the key, right? We need to make sure we understand exactly the disease that our patient is presenting with so then we can present them with the best potential treatment option. Looking at NCCN guidelines, the first-line standard of care for patients with HER2-positive disease is platinum-based chemotherapy with the addition of immunotherapy as an optional sort of choice to include with chemotherapy. In the second-line and beyond setting, when patients are progressing after platinum-based chemotherapy, we do have ADCs or antibody-drug conjugates available, and we'll talk more about that. So first, focusing in on the first-line setting. So platinum-based chemotherapy really is our staple and current approval for patients in this setting. Clinical efficacy of chemo in this setting has an objective response rate of 36%, PFS of 5.1 months. Well, what about immune checkpoint blockade for patients with HER2-mutated advanced non-small cell lung cancer? Immune checkpoint blockade efficacy for these patients, particularly patients in general with oncogene-driven non-small cell lung cancer, tends to be limited, and that includes HER2 mutations. And this is because typically these tumor environments are cold, meaning they have low PD-L1 expression, low TMB. And so this is a really nice figure that I refer to often in clinics, show my fellows as well in training. And this is data from the retrospective immunotarget study, which looked at patients with non-small cell lung cancer that harbor driver oncogenic alterations. And what you can see here is that immune checkpoint blockade by itself in monotherapy has low objective response rates for patients with HER2-positive disease, ranging from 7.4% to 12%, PFS of 1.9 to 2.5 months. So when you take this all together, what I would say is that the available data does not encourage the use of immune checkpoint blockade by itself for the treatment of HER2-positive disease. So we've answered that question about by itself. What about in combination with chemotherapy? And here's the data that I have to present. It's retrospective. So if we look at from some different retrospective studies, including a German retrospective analysis where they had first-line pembrolizumab in addition to platinum-based chemotherapy, objective response rates are about 52%, PFS of 6 months, overall survival of 88% at 1 year. Additional retrospective analyses kind of call into question this PFS benefit. So we do see a 5.2-month benefit, for example, in this additional retrospective analysis, but it was not significant versus chemo alone. And then more recently, the LC Scrum Asia study that was retrospective did show a PFS that was significantly improved, but no OS that was statistically improved. So when you put all this together, yes, chemoimmunotherapy combination strategies are feasible, but it really does call into question talking about the risk and benefits and shared decision-making with patients, which Dr. Newsom-Davis will talk to us more about. So let's now focus on antibody-drug conjugates. We want to get more targeted, if you will, right, to deliver targeted precision medicine to our patients. So this is the NCCN guidelines. We're going back to it, focusing on standard of care. At this time, if patients progress on platinum-based chemotherapy, we do have TDXD or trastuzumab deruxtecan as an FDA-approved option. Additionally, TDM1 is listed as a recommended option on NCCN. Let's focus on TDXD. So TDXD is an ADC or antibody-drug conjugate that targets the extracellular domain of HER2 antibody. It additionally has a peptide-based cleavable linker and this novel topoisomerase I inhibitor payload. Many of us are familiar with the structure and function of TDXD. What I'll highlight your attention to on this slide is that this drug has a high drug-to-antibody ratio, and by having that, that allows for that bystander effect. So that's why we can see that we have this anti-tumor activity even in tumors that are low to HER expressing. So that's really important to keep in mind. So let's focus in on some of the data that has led to the approval of T-DXd for patients in this setting, and that comes from the DESTINY-Lung01 study, which is a phase 2 trial that enrolled patients with unresectable or metastatic non-squamous non-small cell lung cancer. Importantly, these patients had to have had progressed on standard of care treatment. There were two cohorts. There were patients that had HER2-expressing disease and the patients that had HER2-mutated disease, which Dr. Yang has nicely walked us through the differences. And patients were treated with T-DXd dosed at 6.4 milligrams per kilogram every 3 weeks. Primary endpoint was objective response rate. This is the waterfall plot, and you can appreciate the responses that patients have had on this treatment. What I'll draw your attention to, and Dr. Yang really nicely summarized this in his portion of the talk, is that having a HER2 mutation is not always concordant with HER2 expression. So you can see on the bottom half of the figure there, many patients with HER2 mutation-positive disease did not have HER2 expression. So that's really important to think about the different ways that we're testing and what that translates to. If we focus in on the objective response rate from this study in the HER2 mutant subgroup, objective response rate was 55%, disease control rate of 92%. Looking at progression-free survival, median progression-free survival was 8.2 months, median overall survival is 17.8 months. But we also need to focus on the safety just as much as we think about the efficacy. And so 46% of patients on this study experienced grade 3 or greater treatment-related adverse events. The one that we were most concerned about is interstitial lung disease, an incidence of 26% in 2 deaths. The other thing that's really important that we talk about when we're counseling our patients is this is almost like a smart chemotherapy, right? So we need to also focus in on some of the chemotherapy-related adverse events that we typically counsel patients about with conventional chemotherapy. So nausea, fatigue, alopecia, right? These are very important to make sure patients understand. Now let's go to the DESTINY-Lung02 study, which was a phase 2 trial. And importantly, in this study, they restricted enrollment to patients who had HER2-activating mutation. Patients were randomized 2-to-1 to receive T-DXd at 5.4 milligrams per kilogram, which is a lower dose, as compared to T-DXd 6.4 milligrams per kilogram, both given every 3 weeks. Primary endpoint was objective response rate. Secondary endpoints are listed there. And what I'll show you here is the objective response rates. So for 5.4 milligrams per kilogram, it was 53.8% versus 42.9% with the 6.4 milligrams per kilogram. And importantly, we focused on ILD or interstitial lung disease incidence. And you can see here that there was a lower ILD incidence with that lower dose of T-DXd, 5.9% versus 14%. So this has ultimately led to FDA and EMA approval of T-DXd as the first approved targeted therapy for HER2 mutant metastatic non-small cell lung cancer, again, after patients progress on platinum-based chemotherapy. And Dr. Yang has nicely also updated us with the FDA accelerated approval as of April 2024, where if patients have HER2-positive IHC3 plus expressing solid tumors and no other treatment options, we can use T-DXd in that setting. So this is future directions with T-DXd. I'll focus in quickly on DESTINY-Lung04. This is really trying to move this antibody-drug conjugate into the first-line space and comparing it to our standard of care, which is chemotherapy plus pembrolizumab, very similar to that KEYNOTE-189 regimen in the first-line setting. Of course, I do want to stop and pause about brain metastases and HER2-altered non-small cell lung cancer. Many of these patients tend to be young, they're working, developing brain metastases either de novo or during at any point in their cancer care journey can really be a big setback, so we need to focus on that. The occurrence is about 6 to 29%, particularly in patients that have the YVMA insertion. This really does highlight a need for therapies to cross that blood-brain barrier and to improve outcomes for our patients. The data that we have with T-DXd currently from pooled analyses comes from DESTINY-Lung01 and DESTINY-Lung02, and we can see about an 86% response rate in regards to having measurable brain metastases that shrink in size with that 5.4 milligram per kilogram dosing. And of course, the DESTINY-Lung04 study, moving this into the first-line setting, a key endpoint from a secondary endpoint standpoint is CNS PFS, so I'm looking forward to that. Finally, let's talk about something that we're very excited about, and that's the evolving treatment landscape, TKIs. I tell my patients that right now the HER2 space has a lot of FOMO, right? Because we have the target, we know how to deliver that, but we still don't have an approved oral drug, right? So the time is now, and I'm excited to get into it. So the promise of HER2-selective TKIs. So this is a targeted approach. What's really important to understand is that HER2-selective TKIs may offer a better therapeutic index as compared to pan-HER TKIs. So historically, we've had, for example, the drug poziotinib, but that was limited by severe toxicities given sort of the off-target pathways with rash and diarrhea. These are very exciting to see all the future directions of ongoing trials in this space for our patients with HER2-altered non-small cell lung cancer. We have ongoing phase 1 up to phase 3 studies, and we're really going to focus in on 2 key drugs for this talk, zongertinib, BI-1810631, or BAY-2927088. We'll say it as BAY-88 for the sake of simplicity. So let's first focus in on zongertinib, which is studied in the BEAMIAN-Lung1 study. This is a phase 1 study that was presented at World Lung 2024 just last year. And what you can see here is that patients in the phase 1b portion of the study were in cohort 1, and they were randomized to either 120 milligrams once daily or 240 milligrams once daily of zongertinib, which is an irreversible TKI. It selectively inhibits HER2 and does not go against the EGFR pathway to kind of limit those toxicities. And what you can see in cohort 1, importantly, is that these patients were pre-treated non-small cell lung cancer, and they had to have had a HER2 activating mutation. And what you can see here is the waterfall plot. The objective response rate was right around 66.7% for patients with 120 milligram dosing, with one patient achieving a CR, most patients achieving a partial response. So overall, additionally, I will say that there was intracranial activity that was noted. Objective response rate was about 35% in patients with measurable brain metastases. Regarding safety, most common adverse events included diarrhea, but mostly low grade, rash, and an increase in ALT and AST. Thankfully, no treatment-related deaths, and overall well compared to other agents. We just heard actually that the FDA has granted priority review of the NDA for this drug, so this is a lot of excitement for patients, and really excited to hopefully be able to give this to patients in the near future. We'll now focus in on BAY88. This is data from the SOHO-01 study that was also presented at the World Lung 2024 by my colleague, Dr. Xiuning Li. And you can see here that there was the phase 1, phase 2 portions of the study. So the first portion of the study had a dose escalation or backfill, and this enrolled patients with advanced non-small cell lung cancer with HER2 or EGFR mutations. They continued to receive increasing oral doses until a recommended dose was identified, and that ended up being 20 milligrams BID or twice daily. That then went into the expansion or extension phase, and you can see here that what was presented at World Lung was the cohort D. And those are patients that had a HER2 activating mutation or a HER2 exon 20 insertion, and they were importantly targeted therapy naive. Primary endpoint was safety and tolerability, and also PK. Secondary endpoints are listed there. And this was really exciting to see. Objective response rate was 72% for these patients that were targeted therapy naive, with a disease control rate approaching almost greater than 80% here. One patient achieved a CR. There were most patients that achieved a partial response, and then 7 patients with stable disease. If you look very specifically, and Dr. Yang did a nice job sort of highlighting this specific subgroup of patients with HER2 activating mutations, the YVMA insertion group. This was the majority of patients actually on this study with that mutation. Objective response rate increased to 90%, disease control rate of 96.7%, so this was very exciting to see. So overall, I've listed sort of my thoughts. Objective response rate of 72.1% in untreated HER2 mutant non-small cell lung cancer. It's important to also think about the safety profile. So we did see mild to moderate diarrhea. There was about a quarter of patients on the study that did have grade 3 or higher diarrhea, so that's important to think about with regards to supportive measures for patients. Additionally, rash was also a concern. But there were no cases of ILD or pneumonitis, which is something that we did highlight from TDXD. We do have ongoing phase 3 trials in this space. So BEAMIAN Lung 2 is currently enrolling patients. This is the phase 3 study, again, looking at zongertinib in the first-line setting as compared to standard of care chemoimmunotherapy. And then also, respectively, the SOHO-02 study, which is the phase 3 trial, moving the BAY88 drug, 20 milligrams BID, into the first-line setting and comparing that to chemoimmunotherapy. So in summary, we have a dynamic and evolving landscape of HER2-targeted therapies. Platinum-based chemotherapy with an optional addition of immune checkpoint blockade does remain our current first-line approved treatment strategy. TDXD has been approved in the progressive state of disease, but it's exciting to say that we have emerging therapies, notably TKIs that are oral. Maybe the FOMO will finally be filled for our patients with HER2-positive disease, and it's showing promising results. And then lastly, we really do need to focus in on brain metastases. This is a highly unmet need for patients, and looking forward to seeing what the future holds. I'll pass it on to Dr. Newsom-Davis.
Thank you very much. Thank you very much for inviting me to be part of this third talk. So I'm going to talk about education, empowering, and engaging, which is a slightly nebulous subject. But actually what it's about is how do we make sure that someone, for example, with a HER2 mutation, has access to that treatment, they start that treatment, and they stay on that treatment. How do we best support that? It's been a really, really interesting talk to put together, actually, and I hope and I'm sure you will find it as interesting as I did when I was writing it. So first I'm going to talk about, in all of our patients, is the involvement of the multidisciplinary team. You might want to call that the tumour board. I'm going to call it the MDT. And we often say that. We all know that the MDT is this essential part of patient care, and we often flippantly say that. But there's really good evidence behind it, and it's worth remembering these in this excellent systemic review. So the first thing is, if you involve your multidisciplinary team, you're actually going to improve the survival of your patient. This is across many tumour types, not just lung cancer, this data, but improvement in median overall survival with a hazard ratio of 0.6, just from involvement of your MDT. we will actually make the whole process more efficient and a more effective reduction in the time from diagnosis to treatment by almost 2 weeks, just by involvement of your MDT. Treatments, we know there are increased treatment rates. Again, this is in not just lung cancer, but in surgery, chemotherapy, and radiotherapy, just from the involvement of your MDT, and also quality of diagnosis. So if you use, for example, the completeness of staging as a surrogate marker for how well quality of care is provided, we can find that goes up. So your MDT is really important, and everyone within that MDT is equally important. But I'm going to pick out a couple of individual groups here. The first is specialist palliative care. Now, unfortunately, the truth is the majority of patients that Eric and I see are patients with stage 4 disease. These people do not, unfortunately, have curable disease. We've known for a long time that early involvement of the specialist palliative care team is really important. So have a look at the figure on the left. Top left is the traditional way. On the blue at the beginning is, for example, Eric and I being involved. We're seeing a lot of them, of the patient. The patient has not seen a palliative care team. And as they progress through disease and, I'm afraid, come towards end of life, then the palliative care team are involved and we're not. But perhaps a more modern and sensible approach is early palliative care in the bottom figure, where actually palliative care is involved from the very beginning, alongside patients having systemic treatments, alongside those first-line treatment. That demystifies palliative care. It allows early involvement of control of symptoms. And that process, as the patient progresses through their journey, yes, palliative care are involved more and perhaps oncology a little bit less, but it's always hand in hand. And we've got really good evidence and data about the benefits of early palliative care. So have a look at the figure on the right. This is from a study of over 23,000 patients treated in VA centres. So the patients either received no palliative care, that's the black line in the middle. They were seen by the palliative care team within 30 days of diagnosis, that's the orange line at the bottom, or they received palliative care within a month to a year of diagnosis. Now, the patients who received the earliest, within 30 days, had the worst prognosis, I'm afraid. But that, I think, reflects the fact these patients were clearly very symptomatic and, unfortunately, were already at end of life. So instead, please focus on the black line and the blue line. Patients who got palliative care within a month to a year of diagnosis, their survival was way better than those who did not receive palliative care. Survival hazard ratio 0.4. I mean, who wouldn't want a drug that does that, right? There's also a reduced risk of death in the acute care setting, which we know is a poor situation being in an acute care setting at end of life. In the UK, we have something called enhanced palliative care, which is, I guess, what we're showing in the bottom left-hand picture there, which is involvement of palliative care throughout. And we know from that that we reduce the chances of emergency diagnosis admissions. We know that if you are admitted, that duration of admission is shorter. We know there's improved quality of life for patients as measured by, for example, IPOS scales, and it's cost-saving. So we should always recommend early specialist palliative care involvement because of these fulminant benefits for patients. I also want to talk about allied health professionals. So these might be dietitians, occupational therapists, physiotherapists, speech and language therapists. If you ask them the patients they're involved with, you can see that lung cancer is either top or within the top 4 of all of these specialist workloads. And there are all these multiple benefits, which I'm clicking through, for involvement of allied health professionals. But focus on the bottom 3. Improved quality of life, reduced health inequality, and cost savings. It's a no-brainer. So we must involve our allied health professionals and recognise the benefits that they bring from the patients beyond that we're providing through our treatments. So the MDT is a really important thing. I guess outside of the MDT are the patient advocacy groups, and we know they support, they empower, they advocate, and they're representative, and we all work closely with them, and I think they're fabulous organisations. I've put unashamedly the UK ones on the left here, but wherever you are, whether you're in Huntington Beach or you're watching this online in your country, a million miles away, you will have your own advocacy groups, and I would really recommend going to those local ones because they're all excellent. Eric, you gave me some suggestions of ones in the US, which I forgot to put on my slide. On the right, I have a fantastic tweet from Yvonne Diaz, who's one of the patient advocates in the UK. She's a fantastic advocate for the ALK patient group particularly, but you can see it's not just advocating online. She's now recognised in the top 100 influencers of lung cancer. These are really important patient groups, and we should always advocate this, not only for routine care, but also for advocating involvement in clinical trials. There we go. We heard earlier on that HER2-mutated lung cancer is actually more common in women and more common in younger women. By no means exclusively that patient group, but I think we should briefly focus on that. Unfortunately, the rates of cancer, lung cancer in young women is going up, as you can see in the figure top left. And as we know from Stuart, unfortunately, this is more likely patients with mutations such as HER2. And there have been great strides forward, I think particularly in the US actually, of innovative approaches such as the Young Lung Cancer Initiative and particular organisations such as Dr. Flores, who are with her group, focusing on young women with lung cancer and the importance of that. So I think that's one group which we should recognise, particularly with HER2. So we've got all those MDTs, we've got the patient advocacy groups. What about access to testing and treatment? Now, if you're lucky enough to have Stuart in your MDT, you're laughing, okay? It's all sorted. But the reality is you probably don't. And we've got some really interesting data from ISLAC surveys last year about access to testing. So in only 2/3 of countries are more than half of patients having access to comprehensive biomarker testing. So a third are not having it at all. We know from other studies that the lower socioeconomic status, you have reduced access to new drugs and reduced use. We know that biomarker testing varies. It's highest in cancer centres. It's lowest in rural and district general areas. There's not an equity of access or testing. We know that adherence to oral cancer treatments is hugely variable. Studies will quote compliance anywhere between 14% all the way up to 100%, which really means we don't know, but it's not perfect by any means. And we know that poor adherence is associated with worse survival and worse toxicity. So how do we make sure everyone gets tested, and how do we improve compliance? Well, here are a few ideas I've had based on this talk I've created. So we've heard a little bit about biomarker testing. I don't want to repeat what Stuart said, but I agree with all the points he made. Cost is an issue. A third of patients, according to the ISLAC survey, have limited or no reimbursements. It doesn't matter which healthcare system you work in, whether it's an insurance-based system like the US, socialised system like the UK, or a hybrid like Europe. The money's got to come from somewhere, and the reimbursement is a perennial issue for everyone. Time is an issue. 14 days is the median turnaround time in this survey of oncologists and other healthcare professionals. It's an appalling 2 weeks. It's such a stressful time. You know they've probably got a mutation because they've never smoked, they're younger. And you sit there and say, well, I'll wait for results, I'll give you a call when I know it. And they say, how long? And you say, a couple of weeks. And it's an awful couple of weeks, and it's very, very difficult. Quality, we've heard about the difficulty in access of enough tissue, and our colleagues reported over half of pathologists reporting insufficient numbers of quality cells to undertake that testing. Access, Stuart has talked about. And then awareness, I think this is really interesting. In this involved, engaged patient group who replied to this survey, even there, a quarter of people were not aware of the guidelines. So we have work to do in our education. How do we improve that? Well, I agree with most of the points that Stuart has made. I'm not going to repeat them, but education, well, here we are, we're doing education. And I think webinars like this, going out to the broader community, are an essential part of that. I think guidelines are important. They're not the sexiest thing in the world, but if you've got a guideline saying this is what you can do, you can go to your payer, you can go to your regulatory authority and say, look, we've got to be doing this. This is what the international guidelines say. I think patient communication is really important. In the patient letters I write, I summarise at the top the stage, and underneath the stage, I write out all the molecular analyses I found, because I'm telling the patient what I've done. So if they go to another doctor, they decide to hop over the pond and go and see Eric, he can say, actually, the oncologist you've seen, I think he vaguely knows what he's doing because he's actually done the testing. But we've got to communicate that in patients so they know what's going on in their cancer, and they're empowered to find out what the best treatment is. I agree completely about reflex testing. In the UK, we have reflex testing. You have a stage 4 non-small cell lung cancer, you will have NGS done on your sample. That's got to be the standard. ctDNA, Stuart's talked about, I won't repeat that. Patient advocacy groups are very important in championing this, make sure that people know you should have your testing done. You should know what your tumour is harbouring. I think our specialist nurses and nurse navigators have an important role in promoting this and advocating for the patient. And then we have funding. Yeah, money is important, but having the funding without all the other bits is not going to be enough. So we shouldn't just blame the money. We've got to make sure we look at all of these areas to improve access. So we've got the situation, we've got our MDT involved, brilliant. We've got all our allied health professionals, our specialty palliative care. We're lucky enough to have Stuart involved. We've got sorted out our biomarker testing. It's fantastic. We then move on to consent. And the consent process, we always tick the box, like, it's informed consent. Well, in my book, informed consent is the patient has read and understanding what they have consented to. But I think often people don't. Now, the average adult reading age in the United Kingdom is between 9 and 11 years old. So I'm going to repeat that. The average adult reading age in the United Kingdom is 9 to 11 years old. Now, that's not a UK problem. UK's actually got quite a good education system. You'll find that to be the case in pretty much every country. People are not reading at the age of an 18, 20, 25-year-old. They're reading at the age of about a 9 to 11-year-old. On the left here, and this is a slide courtesy of my colleague Adam Januszewski, I'm very grateful for it, is a printout of a beautiful summary of actually pembrolizumab from one of the cancer charities we use. It's beautifully written, it's nice and simple. It's 3,500 words. If your reading age is 9 to 11, that's very difficult to absorb. On the right are two maps of London. On the top is social deprivation index. The deeper colours are the highest deprivation index. On the bottom is proportion of patients in the non-white ethnic group, who therefore, not by definition, but more likely not to have English as a first-line language. So if you're living on the top right-hand corner, in fact, where Adam works around 2 o'clock on that clock, you are likely to have a lower educational level, and English is unlikely to be your first language. And so a 3,500-word document is going to be extremely difficult to digest. So how can we improve this? Well, Adam and colleagues at Bart's Cancer Institute have got some great ideas. On the left is a QR code. You click on that and you get an animated cartoon explaining to you about everything from immunotherapy to side effects to chemo. Great. In the middle, you have a poster in the appropriate languages aimed at the most common groups within that patient demographic about clinical trials. And on the right, we have some videos in English and subtitled in Bengali, or in Hindi and subtitled in English, talking about treatments, talking about access to trials. We've got to do this. This is how it should be. I should implement this in my hospital, because giving out a 3,500-word document is not the way forward, I don't think. If we've consented someone properly, we've got to make sure that we listen to their side effects, because the more we listen to their side effects, the better we are going to be at allowing them to stay on treatment. And patient-reported outcome measured, or PROMs, are key to this. Why should we do it? Because actually symptoms are often undetected by me in my clinic. I run through my standard questions. I know what I should be asking, but I probably don't ask all the right things. Patients won't necessarily tell me because they're worried I'm going to stop treatment. It's well known that patients will often say to a specialist nurse what they won't say to a doctor. We know that physician reporting is not very sensitive, and it's not very specific. And actually, if you've got two clinicians asking the patient the same thing, there's actually very poor correlation and agreement between what the clinicians think. Yet if we use PROMs in this fantastic meta-analysis of over 13,000 patients, you improve overall survival, you improve quality of life, you reduce ED attendance, you reduce hospital admissions, and who wouldn't want all of those things for their patients? How might we improve it? Well, on the left is what we probably have traditionally done. We use CTCAC. I grade the grade 2 diarrhea, the grade 3, whatever it might be. But PRO, or patient-reported outcome, CTCAE, is the next way forward. It's been tested for reliability and validity, and it's tested to detect changes over time. But I think EPROMs, or electronic PROMs, is probably the way forward. This can be done at home. More useful in these oral therapies, can be done remotely. There are a number of different platforms, whether you're in the US or the EU. I think they've got to be validated in each country. It's got to fit in with your individual healthcare setup, which is very different. But I think we've got to be moving to the EPROMs of the world. Because actually, if you're going to look at PROMs, you've got to look at the whole impact of illness. Cast your eye down the 6 areas here in this brilliant report from Lung Cancer Europe produced a couple of years ago, and see how much cancer affects patients. I'll give you a second to read through those. So it's not just about a shortened lifespan, which of course it's there. It's not just about impact of side effects. Actually, it's everything. It's lifestyle, independence, finances, family life, things we're not very good at asking about. And if we ask about side effects, what patients say really bothers them is actually often not what we think. Here is a rank from the same report of the symptoms patients say are the ones that really bother them. Again, just run your eyes down those. At the very top is fatigue, sleep disturbance, things that I don't want patients to have. Am I worried about that? No, I'm worried about neutropenic sepsis and grade 4 diarrhea. I'm not very good at managing diarrhea. I'm not very good at managing sleep deprivation. And yet, that's the thing that's troubling people. I'm not very good at asking about sexuality issues. It can be a bit awkward. I don't quite know what the answer is. And yet, that's at the top of the patient's priority list in lung cancer patients. So we've got to recognize the impact of illness goes beyond the things we probably think are the most important as physicians. So finally, how do we help patients adapt to life with lung cancer? Well, looking at the bottom, starting at 6 o'clock position and going clockwise, I've told you why we should involve a multidisciplinary team, because if we do that, we can have comprehensive assessments. Let's get our palliative care teams involved early. We will improve survival. We will improve quality of care. We should think about things like financial support. It doesn't matter where your healthcare system is. Cancer has an impact on finances, not just health. Psychosocial services, they're not going to be someone in the room who doesn't think that's really important. Yet I find it's the most difficult thing to access. We should access it early. Certainly in the UK, it is one of the first things to be cut when money is tight, and it's a great shame. We should get our patients involved. They should champion what's going on and advocate for our patients, and they do. And we've got to communicate patient to doctor, but also doctor to healthcare and carers. And we should do all of those together to help our patients adapt to life with lung cancer. Thank you very much.
Thank you, Dr. Newsom-Davis. Thank you, Dr. Yang. We're going to go ahead and get started with our Q&A portion. Once again, we'd like to acknowledge and thank our virtual audience. We're so glad you could join us. And a reminder to everyone that's both in person and virtually to please submit your questions through the portal for the Q&A portion and use that Medscape Live Connect platform. We'll go ahead and kick off the discussion while we're waiting for some questions to come in. So Dr. Yang, you very nicely summarized all the different types of alterations we're looking for in the HER2 space. One of the questions I've gotten before from community oncologists, even from my patients, is on HER2 IHC testing, for example, I see a certain level of expression and then the mutation isn't there or it is there. Can you explain sort of the concordance of those testing methods and if one needs to be positive for another to be positive?
Yeah, I mean, and that's a really great question, and we definitely get that question a lot, and in community as well as even some academic centers as well. And I think, focusing on activating HER2 or B2 mutations and HER2-IC, in my mind, they're sort of generally independent biomarkers. I think there's been some studies to show that it's not a great sort of concordance in either coincidence or mutual exclusivity. You can, sometimes you will have 3+ IHC, sometimes you'll have mutation, but there's not really good concordance on the incidence of those two alterations. And so, of course, we need to, keep emphasizing the fact that, the IHC is overexpression, right? And that's using IHC. And then, it's really the 3+, the highest level of expression, that is the most important biomarker, and that's the one that's actionable. If you have 2+ or 1+, there's a lot of exciting data coming out from the breast cancer space, right, with HER2 low, but that's really not the case in lung cancer. We're not going to do, FISH for 2+, because, again, amplification is not an actionable biomarker in lung cancer, at least yet. So we're really focusing on 3+ and basically not 3+. And so I think we really need to sort of continue the education for that. And then for the mutations, again, that's kind of sort of an independent, separate biomarker. And I think we need to do really NGS to capture all sort of the landscape of actionable mutations. Like I said, we can do things like PCR, some sizing assay, but each of those sort of have their own limitations. And I think NGS is really the gold standard going forward to capture all the activating mutations, as well as the other biomarkers that we haven't talked about really today, things like EGFR, BRAF, KRAS. So I think, focusing and emphasizing the need to do NGS on all patients is really important.
That's really helpful. Dr. Newsom-Davis, I'll ask you. So Dr. Yang, in his presentation, we were talking about identifying the alteration, talked about different potential pathways of how we're looking for these different alterations. And so he talked about maybe upfront IHC, having NGS as well upfront. Can you talk us through in the UK sort of what your practice is like? Do you have reflex testing? How do you sort of sequence that testing? What does that look like?
Yeah, so in the UK, we have a national genomics service. So the idea is that every single patient with advanced stage non-small cell lung cancer will get genetic testing. Every single drug for which there is a available reimbursed treatment, that target will be tested. For example, EGFR, BRAF. In the UK, we do not have access to trastuzumab deruxtecan. So therefore, because that's not on the directory, you would think that maybe HER2 is not involved, but actually most patients are getting NGS. They're getting comprehensive NGS, so the result will be there, even though at the moment we don't have access to the drugs. I absolutely agree with you, therefore, the arrival of TKIs is absolutely essential for us. It's a huge unmet need. And the UK is not the only country not to have access to ADCs because the reimbursement is not yet available. The trouble in the UK is that although most places are doing NGS, there are still centres doing piecemeal PCR. They are doing that. They're perhaps running out of tissue. It's quite tissue heavy. They're perhaps not picking up some of the rarer mutations. So we are getting there, but I think it's still a bit of an unmet need, and I think we are on the road to, but not quite yet, in the situation where everyone should get NGS. But I absolutely agree with Stuart that it should be everyone.
Yeah, I think those are really good points, and I think you really highlight the variability in terms of how we're testing and sort of how do we sequence the testing rate for our patients. So even between different institutions, for example, my institution, your institution, Dr. Yang, we've talked about some of the differences as well, so I appreciate that aspect.
I think one thing to add is I think it's really important for people to know they're not doing NGS, to know the limitations of that and what they may be missing. Yes. And I think people often don't.
Yeah. I'll ask you another question maybe about testing before we move on more to the treatment landscape. So often when we get the testing results for NGS, it's lots of pages. You have to scroll through not only the front page, but page 34 or 35. And we are very sort of grateful from the sense that we get to have access to people like Dr. Yang. I can call you, I can text you, right? But that's not always feasible for people that are seeing some of the heaviest burden of patients, if you will, right? Community oncologists. So one thing, how can we help them interpret the results? You listed some incredible resources. And then second, the language can be really complicated. So ERB2, HER2, how do you simplify that? So I'll let you go first, Dr.
Yeah, so I'll answer the second question first. And I think it's a really important issue is the terminology, especially with HER2 and ERB2, because it can get really confusing, right? So I mentioned before, ERB2 is classically the gene and the HER2 is the protein. But sometimes we use HER2 as kind of as a broad umbrella term to describe everything related to ERB2 and HER2. So you're going to see the sort of variability in the usage of these terms, but I think we just have to learn the fact that these can be used interchangeably, even though there are like sort of more scientific sort of nomenclature. But we also have to understand that these can be really confusing, and we should just be more inclusive in terms of calling these biomarkers maybe HER2/ERB2. And so I think it's really important from that aspect because it's going to have implications for not only for the testing but also for treatment, right? So we have to make sure that we're testing for both the IHC as well as the mutation status. So distinguishing those terminology, it can be a challenge, and I think we just need to do a better job in incorporating maybe more of an inclusive terminology. And then your first question was, what was the first question again?
Just simplifying all the language.
Oh, right. And the reports, I think, yeah. Yeah, so the long reports is another sort of issue that I completely agree with you, especially some of these commercial NGS reports. It's like tens and pages, and they have and there are all these the results that are buried in these sort of fine print. So I think we as a community, in collaboration with these diagnostic companies, need to do a better job, I think, in sort of standardizing our reporting, not only the nomenclature for the gene and the mutation, the protein, but also how we present the data. Right? Maybe we should all try our best to put everything that's really actionable on the first page, maybe the first box, sort of highlighting, what we need to know as, what you guys need to know as clinicians and what I need to know as pathologists in terms of diagnosing and treatment. So I think some centers are doing that, and at MSK we try to do our best in kind of making sure that it's very user-friendly, it's readable, and basically highlighting and putting all the actionable biomarkers sort of on the first page. And I think some places are doing it as well, but I think we just need to come up with maybe some sort of a standard across different companies, different practices, and maybe we need some sort of a recommendation or guideline on not only the nomenclature, but also how we present the data in a report.
And Dr. Newsom-Davis, you really nicely highlighted the importance of patient advocacy groups and support groups. That's very meaningful to me. I work with a lot of these patient groups in the U.S. Can you talk a little bit about, one, how we translate these findings so that patients are aware of sort of their disease? And then second, it opens them to a community, right? They're not only understanding their disease, they're not only understanding their treatment options, but they get access to a community of patients, loved ones who are going through a very similar experience that they can relate with and they can connect with. So maybe talk me through some ideas of how we can tap into the patient advocacy groups and communities
absolutely. I think they're a really important part of what we do, important part of all of our meetings. I think your question about how do we translate the findings into a way that is accessible to everyone is really an unmet need. I don't think we do that very well. We'll be on webinars like this. You will see YouTube various snippets of people from conferences, but it's very much an oncologist talking to another oncologist or another healthcare professional talking to another healthcare professional. I think we do need to make the trials accessible. I think advocacy groups do great work in that, but I think we need to improve on that. I think the advocacy groups can be really helpful for everyone. I think we have to recognize, however, that there are some people who don't want to have access to that. There are groups of patients who feel that is too intrusive and want to be separate to that, and I don't think that's negative on them. And I think we need to be able to support them as well. The way we do it in the UK through our UK group, British Thoracic Oncology Group, is we very much want our patient advocates throughout in our presence in our group and in our meetings, and we want them to be able to help spread the word of what we're doing. And you just have to go on the internet and see what they're doing.
Yeah, no, that's a great point. We got a question from the online audience here, and it's asking about how we can bridge the gap between academic oncology and community oncology to really simplify these results, to involve MDT stakeholders. Maybe Dr. Yang, you can talk first, kind of what your thoughts are.
Yeah, I think, in terms of bridging the gap from the community and academic centers, I think we need to do just more education and more community outreach. Sessions like this, I think, are really helpful, but I think we also need to make sure that, that these information that we learn from here, goes beyond these walls, right, beyond our computer screens and into the offices, right, and where we practice our day-to-day sort of clinical medicine. So, and I think, there's a lot that I think different collaborators and stakeholders can do. We talked about advocacy groups. I think they're doing a tremendous job in, highlighting, biomarker testing, access to care, access to diagnostic testing. I think, biopharma is also doing a great job, but I feel like they could do more. There's, regulatory agencies. I feel like there's a lot of room for improvement there, both in terms of, regulating these testing methods, but also in terms of the approval. So I think all of us that are involved in this space, whether you are a clinician, a pathologist, in biopharma, I think we can all really agree that, we can collaborate and do a better job in streamlining testing and also making sure that we understand what needs to be tested, how to test, and what's actionable.
Yeah, I absolutely agree with that. I work in a cancer center. I work out in a district general hospital, so I see both sides of everything. I absolutely agree with that. I think there are some other things we should think about. Targeted treatments, particularly TKIs and HER2, is perfect treatment for the district general hospital, their specialist center, because they're treatments you can give as a day case, as a tablet daily. So I think they're great. I think there's a couple of things one needs to do. I think we need to improve and spread out our education. I think in that molecular report, I think you're absolutely right. I think it's got to be simplified, and people should have access to a genomic tumor advisory board, a GTAB. That's what we have in the UK. Every region has a GTAB. You can go there and, I would hope, ask our judgment, what on earth does this mutation mean? And someone will say, that's a HER2 mutation. This is what the patient should be having, and we should champion that. I think we should make sure that all oncologists know the phone number, or at least the email, of their molecular pathologist. To be able to email them and say, I've got no idea what this means, can you tell me? Because I do that all the time, and I have fantastic feedback from my colleagues. And I think if we make sure that people have to have the testing done correctly and they know the significance of the result, then any oncologist can make sure the patient has the best treatment.
Yeah, I think that's a really nice summary. I think you heard it here first, that really for these practice-changing results, we need to take it to where practice is happening the most, and that's in the community, right, for our patients with cancer. So I think that's a really important point. I'll ask you another question, Dr. Newsom-Davis. So we talked a lot about the emerging therapeutics that are evolving in this space, particularly TKIs. I'm very excited about the 2 TKIs that I've talked about today, BAY88, zongertinib, and then we've seen a list of other ongoing trials. Talk me through what you're most excited about and what we're looking forward to for patients in clinic.
Yeah, I think I am most excited about the arrival of TKIs. I think we don't have routine access to ADCs in the UK. That notwithstanding, I do have some concerns about the side effects. I think the pneumonitis rate is, yes, it's better on the lower dose, but it's still not insignificant. And you have a treatment which is infusional. We've been dying for a tablet treatment for HER2 in the way that we do for EGFR and ALK and ROS. And I think we're beginning to see that. The early drugs were hampered by toxicity. They looked great in early phase studies, but in reality, when they got beyond that, they weren't tolerable. And now we have at least 2, probably 4 to 5 good, effective drugs. I don't know which is going to be the most effective, but it's great to see that. They're active, they're well tolerable. These are things I could absolutely envisage being in routine clinical use in the next couple of years, assuming that the phase 3 trials bear out what the phase 2 trials have shown and phase 1 trials have shown.
Yeah, absolutely. I agree with that. And then the other thing I'll say is just that unmet need of brain metastases, right? That's a really big focus as well. So every time I'm digesting this data, I'm thinking about what is the CNS penetration and how can we help these patients. So with that, if any other further last minute comments, really appreciate everyone being here. And thank you guys so much for participating.